Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another special COVID edition of Children's Healthcare Canada, Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to have the opportunity to be present in this territory. Today, we're delighted to welcome Children's Healthcare Canada member BC Children's Hospital to bring you the new COVID test for school-age children, just swish and spit. As mentioned in the intro, please type your questions into the question box at any time throughout the presentation. I'll prompt you via chat as well, and I'll pose the questions to our speakers at the end of the session. I would like to introduce our speakers for today. Dr. David Goldfarb is a clinical associate professor in the Department of Pathology and Lab Medicine at the University of British Columbia and medical microbiologist and pediatric infectious disease physician and associate department head at BC's Children's Hospital Department of Pathology. And Christy Hay is a senior leader at BC Children's and BC Women's Hospital's Health Centre and an adjunct professor of the School of Nursing at the University of British Columbia. She has over 20 years of healthcare experience and more than 15 in progressive leadership roles within BC Children's and Women's. Most recently, she was the operations chief as part of BC Women's and Children's Hospital and Health Centre's executive team in the organization initial response to the COVID-19 pandemic. It's my pleasure to pass the mic today to Dr. Goldfarb.
Hi, good morning, everyone. And I guess if there's anybody from Atlantic Canada, good afternoon. Can everyone hear me?
Yes, we can.
Yeah, great. So greetings from surprise, surprise, rainy Vancouver, and as well from the unceded territory of the Coast Salish peoples, including territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We do not have any conflicts of interest to disclose related to what we're going to be presenting. And we're going to be, in terms of an outline, we're initially, I'm going to go over some of the background data around sample collection in kids for COVID-19 diagnosis. And then I'll talk about an evaluation we did, a quality improvement, quality assurance project looking at self-collected sample types in kids and adults here in Vancouver. And then talk about some of the practical aspects of scaling this up in BC, which I think we did fairly quickly. And then actually quite importantly, and this is where Christy and I'll both join in, we'd like to have some discussion and hear what's happening if people have experience at their collection centers. And I know this is certainly something that we're changing on a regular basis, how we're doing things and trying to make things better. And I'll talk a bit about that, how different this experience has been. So I think everyone's familiar with either has seen or experienced the nasal-pharyngeal swab. And these are traditionally the gold standard. We've used them for other respiratory viruses, and they've been studied quite a bit, and I've been involved in work looking at that. different groups. So the Canadian Public Health Lab recommended them as a gold standard, and the Infectious Disease Society of America also, in their guidance around COVID-19, did state that they were a gold standard. However, there are multiple challenges when we're looking at nasopharyngeal swab collection, and one of them, which was actually quite pressing in the system in general, not just for kids, was the supply chain issues. So the swabs that we're talking about are actually quite a specialized piece of equipment. They utilize this flocking process, so they have this kind of peach fuzz end to them, and there were only very small number of facilities. One of them in Italy, for instance, provided more than 90% of the global supply. But then when demands had increased, sometimes in some locations 100-fold, those were not being met. And so we were getting different swabs from different suppliers, and sometimes didn't have enough, and just in time was being done. So that was a real pressure. And that's not gone away. And then the other piece is, obviously you need to have a trained healthcare worker for collection. There's personal protective equipment required for nasopharyngeal swab collection. And certainly they're not always well tolerated. And I would say particularly that can be a challenge for children, even more so than adults. So if we look at some of the actual studies that have looked at sample collection in kids, I'm going to do a whirlwind. I'm not going to go in depth looking at each of these studies, but this was one of the first in Italy, where they compared actually mid-turbinate or nasal swabs that didn't go all the way to the back to throat swabs. Again, it was small numbers, N of 11, so total 11 kids. And they found that these weren't throat swabs, that the mouth swabs did not work very well compared to nasal swabs. This was another study. This was mostly in adults, but they did have actually 5 kids, and they looked at mid-turbinate swabs. So these are specifically designed mid-turbinate swabs that bulge in the middle, and they looked at kids and adults, and those seemed to work better, but still not as good as nasopharyngeal swabs. This is where we get into some of the saliva studies. And I think a lot of people may have heard about saliva, and I think Ontario's, for instance, or at least some of the sites in Ontario may be rolling that out this week. So when you're talking about saliva, one of the things I would just caution is that not all saliva samples are the same. So this is one of the groups in Hong Kong that did some of the first work, and they included some kids, but they did what they called posterior oropharyngeal saliva. So they were ensuring that people essentially tried to get the saliva from the back of their throat. And there's no kind of convenient way to describe that, but they described it in their methods. Again, they only had 6 kids, and they were finding relatively good performance, but we didn't have necessarily the age of those kids and how well can kids get saliva specifically from the back of their throat. Here's another study in kids, again, small numbers, 11. They looked at buccal swabs, so they just swabbed the inside of the mouth and compared it to nasopharyngeal swabs. They found you were missing about a quarter of cases with those buccal swabs or detections. And then very recently, just in the last, I think, week and a half, this was in CID, which had a bit bigger numbers, N of 18. This is a group in Singapore. And they compared saliva to MP swab, and they found that actually saliva maybe missed nearly half of the cases compared to detections compared to nasopharyngeal swabs in kids. So not a huge amount of actually studies. There's been more happening more recently. We were designing this back in the end of April and early May, when there was actually nothing really published. And so, one of the things we think about when we were designing what kind of sample we'd want to collect is, where are we trying to sample? And I'm not sure if you can see my mouse, but my pointer, but this is the posterior nasopharynx, which is where you're trying to get with a nasopharyngeal swab. Here's a child, similar image, but this is where we're kind of interested in. And throat swab studies, for instance, also are sampling there at the posterior oropharynx. And so one of the reasons why we chose the gargle sample is that that's where you are sampling when you do a mouth rinse and gargle. And so we wanted to include that. There had been some studies actually in other respiratory viruses that had been published with gargle samples looking promising. And then there actually was a surveillance project for HPV that the CDC ran, where they were actually using gargle to sample for human papillomavirus in respiratory tract. So that's why we ended up including gargle. We also included saliva in our study. The other thing, just to, in terms of context and our recognition of the importance of needing to look at self-collected, we did have a kind of dry run in the spring when kids did go to school and kids were going back to daycare. And what we saw at our collection centers was a very different situation than what you're normally used to, which is, children are only getting tested if it's really clinically indicated. And we often encourage not to test unless there's a strong clinical indication. These were different scenarios where you had, it may be a parent that's particularly interested and wants, to know there may be other, multi-generational homes. It could be from the daycare or from the schools where there is a request that the child get tested before they come back. And so we were seeing, even then, even though it was a very small window and a small proportion of kids went to school, we were seeing children coming back multiple times. And obviously, if things don't go well with that first nasal-pharyngeal collection, then it can be even more challenging on subsequent visits. And so that was one of the other things that kind of led us to feel that this would be an important thing to look at. So I'll describe the kind of gargle method now in a bit more detail and our self-collection clinical validation that we did. We wanted to look for positives, and in BC at the time, we were doing really well in flattening that curve, and we had very few positives provincially. So that was actually a real challenge. And we were asking people to provide additional samples across the Lower Mainland and traveling to people's homes. And we also approached symptomatic contacts of known positives. The other thing we want to ask is about acceptability. And that's not what often people do in these kinds of studies, but we thought that would be a really important piece of information. We tested the samples on multiple assays, and then we also looked at stability. So we left the samples at room temperature because we know there are some places that can't get the samples to the lab for a couple of days. And so we wanted to make sure that at quote unquote room temperature, our lab is 21 degrees, that the virus could still be detected with the different platforms. And so this is the main results. It may be a bit hard to see. This is kind of the table of the 40 positive individuals. And this column here is the gargle sample with our assay that we use at BC Children's. And this is the same samples, the gargle samples, the mouth rinse gargle samples, with something called the Gene Expert, which is a commercial assay that's Health Canada licensed. And we found by both of those tests, virtually all of the positives were detected. We had one missed, and the saliva samples, we were seeing a fair number of them miss. And so we actually, towards the end, you see a lot of saliva samples we didn't collect anymore because we were deciding it was not likely going to be a sample type we were going to be looking at. We had 3 children that provided saliva and nasopharyngeal swab and gargle samples, and 2 out of the 3 were negative for that sample. So this is just a graph as well showing you the yield of the nasopharyngeal swab, saline gargle, and saliva samples by days from when the COVID diagnosis was made in those who were positive. And so we do see, there's some similarities in that first detection, although the gargle sample did have higher yield than saliva even in that first bit, but then it does improve yield even later on with the gargle. This is something called the threshold cycle, or CT values. It's a measure of the amount of virus that would be in that sample, and these are kind of two different genes that our lab detects in our standard assay. When we compared across all three using ANOVA and Box's correction for multiple comparisons, we didn't find a statistically significant difference in the amount of virus essentially we were finding. The mean, though, amount was a little bit lower, but not statistically significant in the mouth rinse gargle. But that's not to be, that wasn't unexpected, because you are diluting that sample. We're using 5 milliliters of saline. It's sampling the entire oropharynx, including posterior oropharynx, but it does dilute it. So the mean amount of virus detected is not necessarily the most important indicator. And then this is just a slide showing that stability piece, and we didn't see really any loss of virus RNA detection even 2 days out. And so we were comfortable that this could be received in most labs by that point and not have significant loss. And then this is just the table showing the acceptability, and this is on a Likert scale, and 1 being the least acceptable, 5 being the most acceptable. And as you can see, we had very high acceptability scores across the board for mouth rinse gargle, and even it was statistically significant in terms of the difference between saliva. Saliva also had pretty good scores, but some people didn't like it. And just anecdotally, some of the issues were that people often have dry mouths, and so it was taking them a while to get us the volume of saliva. And with kids, you were waiting quite a bit to get them, the few that I was involved with collection, especially with younger kids. And certainly nasal-pharyngeal swab was at the bottom of the acceptability. So what about, here's my middle son, and he's looking pretty skeptical there. So can kids actually do this? So we had the kind of data that this seemed to be a very reliable in terms of detection, but then in terms of implementing it, can kids actually do this? So we very quickly implemented in our clinic, collecting both samples. We didn't have a video yet, and we didn't have some other training materials. And these were kind of voluntary. We were collecting an NP swab, and then we were also asking if they could provide a gargle. So you have to take that with a grain of salt, because there may be some people that just wanted the NP and that was it. So we did see, in the 4-year-old group, in our initial, once we rolled this out, and this is just in that first week at our collection center, less than half were able to do that. And but once you got at 5, and certainly once you're in the 6 to 9 or older group, the vast majority of them were able to provide it. And we're seeing that improve now that there's communication. We're instructing people before they come to the clinic through our screening process to watch the video, which we're going to show, because that's been the real piece. If people are aware of it, and hopefully we're encouraging people to practice at home, it makes it much easier to have a successful collection. So there was a decision in early September that we were going to incorporate this in our back to school strategy. And the one thing just to highlight is how short of a timeline this was to get this to the over 93 collection centers all around the province within essentially a week from when we had the materials to do it. So there was a lot to do in a short period of time. we did, and working with, and I'll talk about the teams that were involved, but working with partners, we were able to secure this collection device that you can see there and put together kits that were then, through supply chain at the BC Lab Services, distributed out to all the collection centers. We had instructions specifically as no eating, drinking, smoking, brushing teeth for 1 hour before collection. If that didn't happen, then NP would need to be collected. If there was a failed attempt at the swish and gargle, then we couldn't recollect immediately, because essentially they've just rinsed out their mouth. And so we had said they'd either have to recollect in 2 hours or have a nasal-pharyngeal swab. And we wanted to really make sure that the video and instructions were disseminated as widely as possible. And that included a media blitz with lots of radio and TV interviews, as well as communications through the collection centers. The sample collection is relatively straightforward. We basically had, in our collection centers, if you're indoors, you're wearing a mask anyways. And we had them wash their hands first. The sample container that they received would have the label on it, so they'd confirm that that was the right name for that child or the person having the collection. They then twist off the vial top and squirt it either themselves for older kids in their mouth, or their parent would do that for them. And then they swish it around for 5 seconds and then tilt their head back and gargle for 5 seconds, swish around for 5 seconds, gargle for 5 seconds, swish around for 5 seconds, and gargle for 5 seconds. So the whole thing takes about 30 seconds. It's 3 cycles of that swish and gargle. And then they spit it into that funnel-shaped container, and when they lower their mask, or remove their mask, and then spit it into that container, and then that goes back to the nurse and they wash their hands. So unfortunately, I can't share from my computer, but I think Christy's gonna share the YouTube video, which I think will make it much clearer. And we actually had to contract a production company. Luckily in Vancouver, that's one of the things we have, are people that make movies. And so they were able to do this over a weekend, and I had to recruit my daughter. You'll see myself in it as an actor. Hopefully it's good.
Perfect. Can you see my screen now?
Yeah, we see your screen.
Okay, I'm going to start playing. Thanks, Dave. We actually have called this the Goldfarb Gargle. Dave doesn't like that, but that's what we've named this. So here, I'm going to start playing. Oh. What's going on here? There.
Hi, my name's Nicole. I'm a nurse at BC Children's Hospital. You probably know there's a virus going around right now called COVID-19, which is making some people sick. People who get this virus have a fever or cough or feel achy or tired. We need to do a test to see if it's COVID-19 that's making you feel sick. Once the doctors know what's making you feel sick, we can come up with a plan to help you feel better. This video goes through the steps to help school-aged children provide a gargle sample which can be tested for the COVID-19 virus. It's a good idea to practice this technique using water at home at least 2 hours before you go for testing, especially for younger children. Make sure you don't eat, drink, chew gum, or brush your teeth for at least 1 hour before your test. You can sit with or beside your caregiver, or you may prefer to stand for the sample collection. Before we start, make sure everybody's wearing a mask, unless you're in an outdoor or drive-through testing location, and everyone should wash their hands with soap and water or hand sanitizer. Your healthcare provider will hand you a salt water vial and a container for the sample. Twist off the top of the pink vial of salty water by holding it with your thumb and finger. Have the child remove their mask and hold it to the side. The child tilts their head back and opens their mouth really wide. Firmly squeeze all of the salty water into the child's mouth. The water will taste salty, like the water in the ocean. Some children may do this on their own. Make sure you don't swallow the salty water, or talk, or spit it out. The mask now goes back on to cover the face. Swish the water around in your mouth for about 5 seconds. Then tip your head back and gargle for another 5 seconds. Repeat the swish and gargle 2 more times for 5 seconds each. This will take about 20 seconds. Younger children can spit the salty water into the funnel-shaped container held by the caregiver. Older children can carefully spit into the container on their own. Place the sample container on a flat surface as directed, or hand it to the healthcare provider. Make sure you wash your hands. Remember, just because you had this test does not mean you have the virus. Thank you for coming in for the test. Now, you're all done.
All right.
Stop sharing.
We're not called Hollywood North for nothing.
We were very fortunate too. I'll comment that our nurse Nicole, who works in our emergency department at BC Children's Hospital, prior to entering nursing, actually was in film and radio. So we are fortunate to have a real expert there.
Yeah, so we filmed that on the Friday, and thankfully the company did all the edits, and I think by Tuesday morning we had that version done, so that was really helpful. So we had to do a lot of things. We had to update our pediatric testing guidance, including an appendix on the saline gargle collection. We had to get a lot of information out to the parents through the schools. We had to develop posters, like we mentioned, the video, handouts, and translations. And one of the other things is that it can be self-collected. And so right now it's being done at the collection centers and being observed by staff at the collection centers to give guidance. We are now in the processes of beginning validation for self-collection, where when people come in, they're just going to go into a room with the information sheet and self-collect. And that might change the entire flow for collection centers, if people can do a self-collection and not have to wait in line to see a healthcare provider to do that. Obviously, this would have impact on health, human resources, and PPE. And the cost, these collection devices, we're using an imported distributor or manufacturer, and we're looking at a locally produced option as well, but it's significantly less just in terms of that versus the swab. But you can imagine the other savings that we might see if we get to self-collection. So some of the next steps we are now really working on, and I think every province is, increasing lab capacity and getting more supplies so we can offer it to the broader population, not just the school-age kids. As mentioned, we have a local BC supplier that we're working with that will, if we're able to secure local production, then some of these supply chain issues with things not going the way you'd hoped, it will be avoided. We are also actively really looking at this sample type in our lab, and it seems to be actually quite attractive for some of the higher throughput processes and more rapid testing where we don't need to do extraction. And so that's something we're looking at, which would be a big difference if we can test these samples without extraction. And so there were a lot of people that were involved in this, and you know, and one of the things to highlight, so we're all under the same umbrella here in BC. So our BC Children's Hospital, our collection center, the BC CDC Public Health Laboratory, and the Provincial Lab Medicine Services, we're actually all under PHSA, which is the Provincial Health Services Authority. And that can sometimes be a bit unwieldy. But in this kind of an effort, we certainly found that to be beneficial to have everybody under one umbrella, and people could deal with the validation that was needed across the province and all the other labs. We had assistance from the BC CDC with that, and supply chain and communication with all the collection centers through Provincial Lab Medicine Services. So it was helpful to have everybody kind of working together in one organization. So we definitely wanted to open up to discussion and to hear what other other people's experiences were, and if there are any questions. I see there were a few, which we'll try to look at now. Put on my
The
video
first
so you can actually
question comment that has come in, Shelley comments, it's a wonderful video, and can other organizations share this video on their websites when they start offering the Gargle test rather than reinvent the wheel?
So definitely, we actually have another video we did for nasal-pharyngeal swab collection for parents, which already some institutions have reached out and have been sharing, and we're more than happy for anyone to use that video. We're not getting any revenue either.
No. Both videos are on the BC CDC website under the children's testing guidelines. So
wonderful. And I assume it would be okay for Children's Healthcare Canada then to feature it in their newsletter, provide links to it in the newsletter?
Yeah, absolutely.
Wonderful. Wonderful. And Marie has asked if this will be implemented broadly throughout BC, and when might we expect it coming to the rest of Canada?
So I would say it has been now. We were tasked with rolling it out equitably across the entire province at all the collection centers, from Haida Gwaii to downtown Vancouver on September 17th. And we're still having meetings to ensure that there is access, and we're even trying to get out to some of the nursing centers. And so that's our real goal now, is to try to make sure that everywhere does have access to it. But yes, all the collection centers do have access to that.
Wonderful. In terms of cost, how does this compare to the other mechanisms throughout the whole process, the equipment as well as the processing?
Right. So the collection, like that plastic tube with the funnel top, and then the little. I think a lot of people are familiar with that pink squishy saline. They're used for nebs or wound dressings and things. But that cost compared to your classic nasopharyngeal swab is half or less, just that collection device. And then in terms of processing in the lab, right now we're using the same tests. All the labs, we validate it on 8 different high throughput platforms. And so the testing time is the same. There's no additional processing that has to happen, so it may be even less, because some samples need some additional processing. But we are looking at making it even lower cost to test these types of samples. So we're looking at some of those newer methodologies that I was talking about.
Yeah, there wasn't a full.
And obviously,
Sorry, there wasn't a full, cost analysis on it, but as we move forward, and if we can get to self-collection, you have to think of all the labor costs, the PPE costs, the just all of those added costs that we're doing right now with our collection sites with the traditional NP swabbing, which will be a huge cost savings overall to healthcare.
Has there been approval by Health Canada, and if so, what's the expected time frame across the country? And that's a question from Penny.
So we've had, Health Canada, and that's what we're trying to clarify as well, this is a new method of collecting samples. So it's not a new way of testing them. And so when Health Canada gets an application from a company that wants to have their test validated, they'll say, oh, we've looked at this, and this sample type. And then they need to have shown that they've done a certain number. Within the provinces, we have accrediting bodies. So as a lab, we in BC, it's the Diagnostic Accreditation Program. And so basically we have to have evidence that would make us feel comfortable using that in our labs with our platforms for us to be able to introduce that. So Health Canada, they provide guidance to a manufacturer to say that you need to have 30 positive samples. It's the same as the FDA in the US. So we certainly had more than that, than what was recommended by Health Canada, but they don't govern whether your province can use. It's usually a provincial lab accrediting body that will, that your lab will be accountable to in terms of using a different sample type.
Okay. You mentioned that you had to source some of the equipment. The swabs in particular were particularly, you had to order them from away. I think it was Italy, if I recall correctly, but I can't remember.
Yeah, sorry. Go
How
ahead.
readily available, like what would be the lag time for provinces ordering such equipment?
Do you mean the swabs or these collection devices?
Either.
So swabs, it's a real, like the whole world wants swabs now, and it's been a real challenge, and getting reliable, good quality swabs has actually been a real challenge for the provincial lab folks. But these collection devices are a bit simpler to produce. There's certain things that are needed. It's a plastic container with a funnel top. But that a lot of different manufacturers can make something like that. Anybody that's in plastics can do that. Versus the swabs, like I said, it's a fairly specific technology. That flocked type of material is not that easy to make. So we were able to source it fairly quickly, and I think our provincial group has been in touch with other provincial and territorial groups to talk about this as well, and on a more of a national basis, which
wonderful.
I think makes sense if these are manufactured in Canada.
Oh, great. That will certainly potentially keep the cost down as well.
Mm-hmm.
Taylor has said, recognizing that you looked at tolerability in children, can you discuss possible application for special needs children?
Yeah, so it's a good question, and we need to we're trying to get good data around success at the different collection centers, and so it does require that a child, in terms of the neurological control, to be able to gargle a sample, and so that's something we need to look at. But right now we haven't had that data, but that's certainly something that we need to look at is whether we can look at other options potentially for those children. But right now we've had pretty high success rates overall.
And I would say it would depend. I mean, there's varying functional ability for kids with unique, I like to say unique abilities. So, and even in kids that don't have special needs, they may not be able to tolerate the gargle, just they don't like the salt water taste, whatever. But yeah, so I think that there's some kids, regardless of their abilities, that are going to be able to do the test, and then there's some that just won't.
Great, thank you. Kristen has said she loves the idea, and as a home care nurse and educator, she's curious if any of these tests are done in the home environment with a nurse present or not, and as an option in between being tested at a hospital or self-sampling.
Well, Dave, you did them in the home, right?
Sorry?
You did them in the home when you were doing your validation.
Yeah, I was going to people's homes and doing it in the homes, but the goal would be if we can show that self-collection is as good as with it unobserved as observed, then yeah, there's a lot of options. You could go at a booth and pick up a kit and drop it off in a drop-off box if you get it labeled. So we're in discussion with some, including IT companies, to look at ways of making this. You could have these kits, for instance, at the school. Child has to go home, they take a kit home with them, or they're distributed through the schools, and then if a child is symptomatic, they can then take it and drop it off. It'll be pre-labeled that way. So there's lots of ways that this could maybe be rolled out in the home setting. As you saw in the video, it's pretty it's relatively straightforward process, so we think it would go well in the home setting.
Wonderful. Penny asks, given the reliability of the test, is there any plan to use it in adults?
So there's a lot of interest in using adults. We wanted to build a capacity, and I was in very much agreement with others in the province that we needed to get this out to the school kids first as a priority, because it was going as part of the back to school initiative. So I was in agreement with that we first make sure that we can get it equitably out to all school-age children. But yes, the next phase, and there is, a lot of interest in scaling this out to adults, because it did work just as well in adults.
Oh, wonderful.
Right now, we're working on our supply issues, as well as ensuring that all kids have access to the method first, and then we'll work as a provincial group to see how we can roll it out with lab capacity and supply capacity to the rest of the province.
Yeah, I think this really could be a game changer in testing, in terms of the long lineups we've seen with
Exactly.
COVID testing because the child has sniffles in the school, or how might it help us better understand COVID in children?
Well, certainly, we've been, and I'm working with research groups, so you can do research studies a lot easier, I think, when it's a gargle sample that you're collecting than having to do recurrent nasal swab samples. So a lot of these research studies where they're trying to understand it in kids and in the school setting, they need recurrent testing. So if you're going to do surveillance, are you going to want your child to have a nasal-pharyngeal swab done every week? Probably not. But a gargle every week is probably a lot less of a barrier to participate in a research study. So definitely, I think it would be. And we've put in an application to look at studies using this sample type for surveillance purposes as well.
And how might it help us keep schools opened during this second wave?
So that was, what I was somewhat alluding to. Like, I think the pressure for kids to get tested is not coming from the usual places that we're used to. Like, we're usually used to, child's coming in a hospital, clinician wants to have them tested to know what's going on. These are often, the child may have some symptom that maybe the parent doesn't agree is a real symptom or is what their baseline is, but the daycare provider or the school feels that it is a symptom that needs to get tested. And so there can be some ambiguity. And so this is a way that we're hoping there'll be better access for testing and less friction and less, discomfort. And I think what we found in that initial spring is that was what we need. We need to have kids easily have access to safe and with the least amount of discomfort testing. And so that's what we're finding, is that we're still seeing kids coming on multiple occasions. And we've heard from numerous people that this makes it so much easier for their kids to go to the collection centers when they know it's going to be a gargle sample than an NP swab.
Makes sense. Anne-Marie has said, we're hearing from parents that they've been advised by their schools to just stay home if the kids are sick and not get tested. Could you comment on that?
Right. So I think that's a big piece, is in different provinces and territories have different guidance, and not every child that has any symptom needs to get tested. And so our province in BC has certain guidance, a runny nose on its own that goes away within 24 hours, you don't need to test, or a sore throat. But definitely not every child needs to get tested with every symptom. But we're not turning people away if a child has symptoms and they come to a collection center. And that may be because the parent would like them tested or the child feels like they want to get tested. We're not turning those away who are symptomatic. But there is guidance on when you should. So there's a difference between when you can get tested and when you should get tested. And the school-based guidance, which I think has been rolled out already by all the provinces and the territories.
Oh, wonderful. What are your next steps with this research?
So the big thing is that self-collection. So we're trying to validate that, because obviously if you can do a reliable self-collection unobserved, then that would change how we will have our entire collections in the entire province, because then you're looking at none of these drive-throughs and you can have a whole different model on how collections occur. And then the other big piece is looking at how we're actually testing the gargle samples. And so we're doing a lot of additional work to see if we can actually dramatically increase our capacity through this new testing methodology, the gargle. The problem with some of these other sample collection type, like the swab, is like I said, we have one type of swab coming in, then another, and then another, and then you have to do this whole evaluation across all the labs. So now we at least have a reliable type of sample that all of the labs can work on and know that that's going to be consistent. And then we can really drill down how we test that sample, and you can actually get a lot of efficiencies through that as well.
Thank you. Sarah asks, is there a way that an independent school can be part of the research study as it gets rolled out?
Yeah, I mean, I think right now we're focusing mainly at the collection centers where we're doing a lot of this work. We have approached some other schools about some of these surveillance research studies. I think you have our email. I don't know if you're in BC or not, but you can certainly email us and let us know, and I can maybe put you in touch with somebody in your region. But definitely we're not, turning anyone away in BC right now.
Wonderful. This is my opportunity to prompt the folks in the audience for any last minute questions. We've run through the questions that they've posed so far. And seeing none pop up, I just want to thank you, Dave and Christy, for sharing your time and expertise with us today. Thank you to all of our members and other attendees for spending this time with us. And we hope you depart with some practical knowledge to bring back to your province or organization. We have a packed fall Spark Live webinar schedule, and next week on Tuesday, September 29th at 12 Eastern, we're hosting another special edition of Spark Live for More Than Medical, supporting NICU families with their transition home during a pandemic. And on Wednesday, September 30th, during our regular Spark Live time slot at 11 Eastern, we'll be hearing about championing pain within your organization in the time of COVID. As well, registration is now open for our annual conference taking place virtually from November 16th to 20th. To register, visit our website at childrenshealthcarecanada.ca. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to David and Christy for supporting our webinar program. And hopefully we'll see many of you back here next week. Bye, everyone.